Good afternoon, good evening, everybody who's joining us. We're just going to let a few more people come in over the next couple of minutes before we get started, but we'd love you to say hello in the chat and let us know where you're joining us from. It's always fun to see where people are within the UK or wider afield, so we get an idea for that. My name's Libby. I'm one of the faculty on the MSc programs at QMUL, and we'll be keeping everybody going through this evening's webinar. I am joining everybody from Scotland, by the way, so that's where I am tonight. Tim is in Qatar, Darryl is in, and Chet are both in London, I think. So got a bit of a geographical spread of the four of us.
Yeah, welcome everyone to the talk on snake bites and everything. Chet and I will be giving it in a moment or two, so hope you enjoy it.
So as I just said, this evening's webinar is going to be recorded, so please be aware of that, and by staying on this, you're giving consent for that to happen. We will have the talk from Chet and Darryl, who I'll introduce shortly, followed by some Q&A with them. So do please put your questions into the chat box, and we'll pick them up from there. After that presentation, we'll then have a presentation from Professor Tim Harris, who's going to tell you a bit about the MSc programs, both the emergency resuscitation medicine and our new one, which is tactical military, austere, and operational medicine that is starting this September. And again, there'll be a Q&A, and you'll be welcome to ask any questions that you may have about that. I can see we're joined by some of our other faculty here tonight, which is great, and some students, and welcome to everybody else who is new to one of these webinars. So without further ado, I'm really pleased to introduce Darryl and Chet, who are both colleagues of mine, as we all work as senior lecturers on the MSc programs at Queen Mary's University. Darryl is a specialist emergency medicine physician at Queen's Hospital in East London. He's also a senior lecturer, as I said, and he worked previously in South Africa and did his PhD in snakebites in Southern Africa. So he's going to be talking to us tonight about the in-hospital management of snakebites. Chet is also a consultant in emergency medicine based at Brighton and Sussex University Hospital on the South Coast. He is the founder of the Tulsi Foundation, a voluntary organisation that provides pre-hospital and trauma care training in tiger reserves in central India. He's a medical advisor to one of India's leading wildlife charities, which is called the Wildlife Conservation Trust, and is based in Mumbai. And he has a hospital in the interest in the pre-hospital management of venomous snake bites, developing resources for the pre-hospital management of snake bites. And this is the area he's going to concentrate on tonight. So I'm going to hand over to Darryl and Chet.
Thanks, Libby. If that's okay, I'm just going to share my screen, and then Chet is going to kick off with some global perspective in the Indian subcontinent perspective on snake bites. So just a quick one, and there we go. So Chet, you're going to take it away and start the snakebite talk. That's all right.
Okay. Thank you, Libby. Thank you, Darryl, and welcome everybody to our QMUL webinar. Next slide. So again, as Libby and Darryl mentioned, we're going to talk about the kind of EM side of snakebite management, and we'll talk a little bit about the global perspective. And my main interest is actually in the Indian subcontinent. So I'll talk about snake bites in the Indian subcontinent and a little bit about first aid, and also a little bit about One Health and a little bit about snake bite prevention, because I know we all talk about antivenom, but in some parts of the world, antivenom is not available. So talk a little bit about human-wildlife conflict, which is an interesting thing. So can I have the next slide, Darryl? So again, what are our learning objectives? Is basically considering that snake bites are not just a random thing, it's a serious neglected tropical disease globally, and also can be linked as a disease of poverty. So even though we may not see it as an issue in the UK, I think in most parts of the world, it is a problem. Again, there's a global burden. I'm going to focus on the Indian subcontinent perspective. I think Darryl will probably shed more light on the African perspective, and we'll talk a little bit about the pre-hospital management, do's and don'ts, and the management of venomous bites. Next slide. So I think the first thing I want to do is to get some clarity on the terminology. We're talking about venomous and not poisonous. Things are poisonous if you bite them and eat them. Venomous is if they bite you. There's only one snake, the tiger keelback, which is both venomous and poisonous. So if you cook it on a barbecue and eat it, you'll become unwell. And if it bites you, you'll become mildly unwell. So let's get the terminology right. We don't talk about poisonous snakes, we talk about venomous snakes. So toads and other kind of amphibians are poisonous because they excrete toxin into their skin, but the majority of snakes we're talking about are venomous. Next slide. So we'll talk about a little bit about the epidemiology, and you can see here, this person's been bitten by a viper, and you can see the tissue damage that's occurred in a very short space of time. So when we talk about snake bites, we talk about death, but we forget about the hidden disability, because if you're a poor farmer, you've been bitten by a snake and you lose a limb, that's your livelihood gone. So I think, we've got to remember that even though there are 1 million snake bites globally, and in India alone, nearly 60,000 deaths, many, many more will be maimed and lose their livelihoods. So I think it's important to look beyond just the deaths, but to look at the social implications of snake bites. And again, there is a call to make it a notifiable disease, but you've got to remember that in countries like India, where registries are difficult and access to healthcare is difficult, it's a challenge to actually get people to record data accurately. Again, we'll talk about the big four and the source of human-wildlife conflict between humans and snakes. Next slide. So this is a really, really important slide. And I would say this is probably the most important slide in my set, because it makes you, if you look at snake bites, 30% of all snake bites in the Indian subcontinent are venomous, and 70% will be from non-venomous snakes. In addition to the 30% that are venomous snakes, only half of those will deliver a venomous bite. So snakes don't like wasting venom. It takes them a lot of energy to make it. So half of all venomous bites are dry bites. So you've been bitten by a cobra, you can see it's a cobra, but there'll be no venom inside the bite. Now, this means that, with my maths, 70 plus 15, it's 85. So 85% of all bites in the Indian subcontinent from all snakes will be non-venomous. And this is the key reason why people try kind of a non-medical treatment as first aid, and it works because the bite was not venomous in the first place. So I have seen some weird and wonderful treatments of snake bites. One was you crush lemon peel, mix it with gunpowder, put it on the bite site, and then light it. And I said, what happened next? Well, we blew that part of the skin away. Another thing is we make them drink kerosene to get rid of the poison, the venom. We saw one man who had his finger chopped off. As soon as the snake bit, the sort of rather than it spread, we chopped the finger off. So most of these non-venomous bites can still result in the view that, kind of lay treatments do work. And I think that is the big challenge where there's lots of misinformation. So remember that in India and the subcontinent, 30% of all bites are venomous and 70% non-venomous. So, if you get bitten, there's a good chance that you won't get envenomated. Next. So why do people get bitten? So, people living in rural areas, working without proper footwear, working without torches, they're in fields. And the problem is that at harvest time, you get a lot of rodents that will come to the fields for food. And then people will be sort of plucking tea or kind of cutting their sheets, and they get bitten. There are also people who are living in insecure dwellings where snakes in the monsoon think, aha, I've got a good place to nest, and they'll come in somewhere dry. And again, poor hygiene in terms of getting rid of waste. So food waste attracts frogs and rats, and rats and frogs are, will attract reptiles like venomous snakes. So again, the way humans are living will actually create a human-wildlife conflict. And again, cultural practices believes people in India especially consider the cobra as a god, and snake charmers are still kind of popular, even though many places they're now banned. But people sort of now also think it's quite cool to post videos of snake rescues and end up getting bitten. Next slide. So let's talk about the big four critters that are responsible for the majority of deaths in India. And basically there are two families. We've got the vipers, which are the saw-scaled viper that you see above, and the Russell's viper, which actually kills more people than most of the other big four. So you've got the two vipers, which, as you can see, have got a very good camouflage and incredibly quick striking range. The saw-scale's the smaller of the two. And the thing to remember about the vipers is that they're more kind of hemotoxic, though the Russell's viper also has a neurotoxic component. Now, if you get bitten by one of these two, the chances are you're going to develop a disseminated intravascular coagulopathy. Russell's viper venom is used as one of the tests for clotting. I think it's used in the UK, but you get presented with bleeding gums, kind of hematuria, big bruising, and skin damage. And I'll show you a couple of pictures in a minute. Okay, so those are the Russell vipers. And you can see here, this chap was bitten on the finger. So that's top right, bitten on the finger by a Russell's viper. And you can see there's a kind of a local blister and a kind of a purpura that develops. That blood blister gets bigger and bigger, starts to track from the finger to the back of the hand. And within an hour or so, suddenly you've got skin loss, tissue loss, and you've got necrotic tissue, which will probably need quite marked debridement. So this is basically a Russell viper bite, which has got very potent local effects. Again, you get generalized bleeding. Can somebody stop moving the cursor? It's going all over the shop. Generalized bleeding over the gums, hematuria. Now, the interesting thing about Russell viper bite, again, it's got a little bit of neurotoxicity too, and it's quite common to have a visual disturbance, ptosis, and a facial palsy, and ophthalmoplegia. So again, even though its majority is hemotoxic, it has got some neurotoxic. And one of the kind of strange things that we just still don't know completely why is it gives you a unilateral parotid gland swelling. And if you're going to be having lots of tissue breakdown and blood breakdown and kind of hemolysis, you're going to get renal failure and rhabdomyolysis, which is a kind of a late onset feature, and you get the kind of dark Coca-Cola urine a few days later and kind of acute renal failure. It also causes the pituitary to become necrotic and become avascular. So people who survive it can get hypogonadism, and it affects their growth. And again, for a significant bite, which is not treated with antivenom, you'll get DIC and multi-organ failure and death. So basically, this is really a big problem in India. And one of the issues is that Russell viper looks very similar to a python. And I know a couple of people that thought to rescue a python thinking it's non-venomous, and it's actually a Russell viper. So you've got to be slightly careful on which kind of snakes that you handle. And this particular one was one that was brought to me to have a look at. And I think one of these, if you're in the presence of it, you can hear it about 30 foot away because it's got a very, very loud hiss. So next slide. Okay, so this is basically one of the elapids, and there are two that we need to worry about, the cobra and the crate. And everybody's been kind of familiar from from childhood with the cobra, the pose, and that it's actually a venomous snake. Now, the spitting cobra, in addition, can cause ophthalmic complications and blindness. But India, the world's largest kind of cobra is the king cobra, which basically is incredibly intelligent. They grow up to 19 feet long. And I happen to know one in northwest of England in the unit where we look after venomous snakes. So these sort of are a problem, and they're potently neurotoxic. And one of the things you remember about the cobra is actually it's a very painful bite with local swelling. So you don't get the bleeding like you would with a viper, but you get a very painful swollen part. And that's how to tell the difference between a cobra bite and a viper bite is actually the bleeding on the site, the swelling and the pain, but without the kind of generalized kind of hemotoxic component. And the onset can be anything between 30 minutes to 6 hours. Next slide. Again, so these are potent neurotoxins, which will cause ptosis, difficulty in breathing, diaphragmatic paralysis. But the thing is, the crate is slightly sneaky fellow. So the issue with the crate, it's a lot smaller, it's a slender snake. It usually bites people in the night between 1 a.m. and 3 a.m. is basically, we've got a study from India where they've got maybe 8 years worth of data, and all the crate bites were in the middle of the night. The thing about a crate bite is there's no pain at all. Some people think they've been bitten by a mosquito and it's actually a crate, and they don't wake up in the morning because they've had bitten in the middle of the night and a respiratory paralysis and they've died in their sleep. Now, we don't know why crates bite in the night and why people are sleeping on the floor, There is one rumor or view that the snake is actually going for warmth, will go and cuddle up with somebody, and then they'll turn over, squash it, and the snake will bite. The other thought is the vibrations from people's breathing, if they're snoring, may make the crate think it's prey. They'll go and investigate and then actually have a little nibble and then disappear. But, you know, crate bites are incredibly neurotoxic, and usually you get respiratory paralysis and death within, you know, a very short space of time. So these are the four big ones which will cause death. And I think the Russell's viper is probably high on the list, followed by the cobra, then the saw scale viper, and then the crate. So what are we doing about these treatments? So we all talk about antivenom. Yep, give antivenom. But if you realize, you're in the middle of the forest. So we did a study in central India, you know, and involved 1,500 people. And the survey was they'd have to travel 40 kilometers, 36 kilometers, often on foot or with no transport to get to a place where they've got antivenom. So you know that there's going to be a challenge in actually getting proper care. So what is the best treatment, pre-hospital treatment for a snake bite? The literature, there is a kind of a systematic review, but it's actually partially complete. And there's been several things that have been proposed. But Professor Worrell, David Worrell, who's one of the world authorities on bites, is basically at the moment suggesting the pressure pad. And the evidence between the pressure pad bandage was a study conducted in Australia a few years ago, where they injected synthetic venom into the vein, and they found that 70 millimeters of mercury pressure on the wound itself, with a kind of immobilization of the joint above and below, could actually significantly suppress the spread of venom. And this is basically what we're doing currently, is that you've got a cotton wool roll, like a bandage, you hold it over the point of the bite, and then you wrap another bandage over it quite tight, immobilize the limb, and then take them to hospital. And it's meant to reduce the spread of the venom. However, no one's actually followed this up and to see how effective it is, but that's the current state of play. And no one is now advised to use ligatures or tourniquets, which will cut off the blood supply. And remember, that 85% of bites are not resulting in envenomation. So you're losing a limb for a bite, that's not going to cause a problem, but this doesn't do any damage at all.
Chet. Shall we get to some of the last slides quickly?
Yes.
Okay, just let me know.
So this is basically one of the pre-hospital ways to move a patient in between two people. And again, the pressure pad bandage is what's been approved at the moment, but very little research. And again, don't use tourniquets, don't incise the wound. Suction devices don't work. Don't suck the venom. You'll get Hep B, Hep C. Don't massage or wash the area because you'll spread the venom. Keep the patient comfortable. If it's a neurotoxic bite, don't give them anything to eat or drink, or don't delay transfer to definitive care. This is a case scenario of a real life friend of mine who got bitten by a venomous snake, and she actually did a whole video recording, and that was the actual snake that bit her, and she was transferred and she's now fine. And I had to give phone advice for a day and a half while she was transferred to a hospital in Borneo. Next. So in summary, we know it's a global health issue. Snakes play a crucial role in disease prevention. And again, they are important in the biodiversity because they help remove some of the pests from rodents. And I think it's important that all kind of healthcare professionals, even in the UK, because there is a large number of people that actually keep venomous snakes in the UK. So again, I think it's important, even if you work here, it's important to be aware of them. And I'm not sure if there's a little video that works. It may work, it may not work.
I can certainly hear the rattling.
That's a little, that's a...
Thanks.
There you go. That's right.
Thanks, Chet.
So handing over to...
Brilliant.
Darryl.
Great. So I'm just going to take off on lots of treatment conundrums we have. Snakebite's actually a diverse field. It's toxinology, which is the toxic effects from envenomations. It is resuscitation, includes surgery, and it's a public health and tropical disease. It's actually a neglected tropical disease. Treating this can be quite challenging. Now, how do patients present? And this is pretty obvious what we see here. This is a little toddler we saw, bitten on foot while playing in grass, obviously painful. Mum brought the child in crying with some slight blistering initially, and you can see it's significant blistering. The problem with snake bites, particularly in Southern Africa, is identifying snakes can be almost impossible for those who are not herpetologists or snake handlers. So the question is, how do we treat these snakes and snake bites? And so what we go for in Southern Africa is what we call syndromes. So we had the big 4 snakes from the Indian subcontinent. We have the big 3 syndromes. So if you think about it, you can sort of guess to maybe 1 or 2 syndromes. That'll be quite good. But let's have a look at the first one. And the first one we call is painful progressive swelling. It is what it is. It's really painful bite, and the swelling progresses. And in this photo, you can see we've demarcated lines on the child's arm on every hour how the swelling progressed. And most of our presentations are what we call cytotoxic. The snakes we normally associate with this are the Mozambican spitting cobra, which is the most prolific biter in Southern Africa at the top, and then the puff adder or Bitus areatans at the bottom, and that delivers a punch. So puff adder bites are notoriously severe. Another syndrome we have is bleeding. And as you saw with the Russell's viper in India, we have probably the most potent venom of any snake, which is the boomslang. Boomslang is the right way to say it, not boomslang as most people say. It's boomslang. It's an Afrikaans word, but that produces a pure hemotoxin. It's universally fatal. If you get it, you will die from bleeding. Blood products, clotting factors, FFPs, you name it, platelets do have no effect. The only effective treatment for this is a boomslang specific antivenom, which is highly effective. And we had a few deaths resulting from the fact that we didn't have enough antivenom for these bites. You do get mixes. The Gaboon viper is notorious. It's you've got the biggest fangs and delivers the most venom. And besides its massive cytotoxic effects, it also causes bleeding, but mainly through capillaries, fragility, damage to tissue surrounding blood vessels. And you get large ecchymosis associated with it. The last one is the one we all fear, is progressive weakness. Exactly what it is. It's a neurotoxin acting at the acetylcholine receptors. And what you get is slow progressive weakness. Starts with the eyelids, ptosis. You get circumoral paresthesias, and then hypersalivation. And the endpoint is really paralysis of the diaphragm and the intercostal muscles and death. So this is the black mamba and the cobra species. Scary and also can be fatal. So how do we treat severe cases? Always antivenom. In our setting, we use polyvalent antivenom and also the monovalent for the boomslang. Just remember, earlier is better. The longer you delay your antivenom, the less effective it is. So when you're treating with antivenom, you need to have the patient in a high care setting or a resus setting with full monitoring, 2 IV lines. Once you've given that polyvalent antivenom, you need post-procedure monitoring for at least 4 hours. This is because there's a high risk of anaphylaxis associated particularly with the polyvalent antivenoms. The dose, well, dosing in our setting, we would normally mix 5 vials in 200 mils. The rate at which you deliver antivenom does not affect the risk of anaphylaxis. So you can give it fairly quickly rather than slowly. There's no advantage of giving it slowly. Also, a test dose is not recommended because you can still get your anaphylaxis on a test dose. Now, age is a problem because the dose is not related to age or weight. So little toddlers and babies need the same dose as adults, and it's all related to the amount of venom that is needed in the person and the amount of antivenom needed to neutralize the venom. So it's a challenge in children, and you might need to give huge doses if a huge envenomation has occurred. Right, surgery. Probably this is where the trauma aspect comes in, is who gets surgery and when do people get surgery. And in a lot of cases, this is the majority of the cases go this route. In our setting, in our studies, we did about a quarter of the patients coming in with painful progressive swelling will require surgery, We normally wait about a week because there's an inflammatory phase, and that has to settle before surgery takes place, so you can see clear demarcation lines. And also you want the coagulation to be normal and the platelets to be normal. Envenomation will reduce platelets and drop them significantly, and sometimes affect your INR profile. Actually, anti-venom works really well to restore coagulation parameters almost immediately. The big thing is compartment syndrome. Who do we do fasciotomies on? You can see from the picture below, it's a morbidity. It causes massive scarring, and certainly the advice of doing prophylactic fasciotomies is not recommended, and that's worldwide now. And the reason is very few snake bites actually have intramuscular compartment swelling. And fasciotomies have heralded this with a healthy muscular bed. What we did in a study was we tried to ascertain where the swelling actually exists in snake bites, and we did ultrasound with high frequency probes over the area of maximal swelling on the affected limb, and we compared this to the normal limb. Now, if you look at the ultrasound, I'll just bring it up. You can see where it says peroneus on the left, envenomed limb, and peroneus on the right, normal limb. There's actually very little difference. I'll just give you a schematic on that between the size. So the intramuscular bed, which is in the pink there, is almost the same size on both limbs. What is significant is where the arrow is the subcutaneous swelling. And in our case series of almost 50 patients, every patient bar one had normal muscular size, but they all had significant subcutaneous swelling. The one case that had where the muscle bed was enlarged and swollen did have a fasciotomy, and it showed an ischemic muscle bed. So, but this is a small study and we can't draw massive conclusions from this, but it does help you in eliciting where the swelling is taking place. A final word is on anti-venom. This is a big area. And how safe is it? So in Southern Africa, 12% of patients, which is quite a high amount, coming to hospitals will receive antivenom. And of these, up to 45% will suffer a severe anaphylaxis in shock, particularly with the polyvalents. The monovalents and the fractionated antibody antivenoms, which are quite expensive to produce. They require papain and pepsin and various enzymes to purify them. They're too expensive, and most developing countries can't afford them. So the polyvalent, we have 10 species of snake in our polyvalent, has a high risk of anaphylaxis. And that's why we advocate giving this in a resus scenario. Why does antivenom fail? We give antivenom, sometimes it fails. The reasons are, one is delayed administration. The quicker you give it, the more effective it is. If you delay it too long, it really becomes ineffective. And then the snake species, some species are not included in the antivenom, and obviously the antivenom won't have effect on that. And dosing can be inadequate. You need a significant amount of dosing for that. So we can offset the anaphylaxis with prophylaxis, but the evidence shows that the only drug really effective for reducing an anaphylactic shock is adrenaline pre-dose, and if you do go into shock, post-dose. And it can either be given intramuscularly or with a low-dose adrenaline infusion throughout the administration of the antivenom. Hydrocortisone is not effective in the acute phase, but it is worth giving because it does reduce a type 3 serum type sickness about a week later after the patients have received antivenom, because that's when you get your joint pains, fatigue, and that can be effective. And then finally, antihistamines have not shown to be effective. And the reason for this is the anaphylaxis is not a type 1 histamine-related hypersensitivity reaction. It's actually a complement fixation and sedimentation, and that causes massive vasodilatation. So antihistamines are not shown to be effective at all. People still use them. I don't think it's a big deal, but the meta-analysis done shows that it's not effective. Final case before I close, Here's another syndrome, little toddler, 2-year-old, bitten to the thigh. We can all guess what's going on here: weakness, ptosis, salivation. And I put drowsy in inverted commas. These patients are not drowsy. They just can't open their eyes. The ptosis is making them appear drowsy, and their lack of movement from the muscle paralysis makes them appear drowsy. They were lucky. The patient came in within 30 minutes. There's the snake. Unfortunately, the snake was killed. We don't advocate that, especially this snake. This is a black mamba. Okay, and it's a big one. So they're lucky they didn't get bitten, whoever tried to kill the snake. And then finally, we gave 10 vials of antivenom. No, thank goodness, no anaphylactic or allergic type reaction. And 2 hours post-bite, patient is sitting up. And that is when antivenom is really effective in the early phase. And so if you're going to give it early. We did a recent paper in Toxicon and a series on pediatrics. And without a doubt, children are at much higher risk of severity and of complications of snake bites. So when you get a child in with a snake bite, be aware that this is going to be a stormy episode, whether you give antivenom or not, and they actually have a higher risk of anaphylaxis as well. Thank you. That's all. I'm going to stop sharing my screen. Those are all the medical officers and doctors and everyone who worked with me. And unfortunately, you can see the number of snakes that were killed, which we really don't want to do. Thank you.
Thank you so much, Chet and Darryl. That was really great. And I learned a lot listening to that. What I learned is if I'm in India, I've got an 85% chance that it wasn't actually venom. So I won't drink kerosene and I won't let them explode my arm. When I turn up in hospital, I'm going to make sure I have a really large dose of adrenaline to back up the adrenaline I've already got within me before they give me any of the antivenom. And then hopefully I'll survive. So couple of questions coming in, and please do type in any more questions you have. Hoping for the ultimate solution. Is there one antivenom for all bites? Darryl.
So the answer to that is no. It depends on what region you're from. So in West Africa, we have antivepnin and pan-African antivenom, but they have a number of snakes included species in their antivenom. Southern Africa, it's all related to the region you're in. If you're fortunate and from Australia, you can actually test to see which snake has bitten you with an antigen type test, and then you can direct a monovalent, meaning only to one species antivenom, which is lower risk and more effective. But for the most part, developing countries target their antivenom to the species in that area. And that's why we have, in Southern Africa, we have 10 species, because we don't actually know which snakes have bitten the patient.
And I was going to ask that, whether you could tell from the bite or anything by which snake it might have been bitten with, because obviously I know if I'm being bitten in the middle of the night that it's going to be the crate that's got me probably, and it's sort of deadly stealth attack. But how else can you tell other than doing monovalent tests?
Well, that's why in Southern Africa we do syndromes, and in South Africa, if you had a bite at night, it would be the Mozambican spitting cobra, which seems to like climbing in bed with you and then proceeds to bite you multiple times. So it's quite a horrific, and we had many presentations like that. It's just something from a horror movie. But you don't know. One thing you can see is sometimes the distance between the fang bites. You can ascertain the size of the snake, because obviously if the greater the distance between the fangs, the bigger the snake. It sounds creepy. And otherwise you don't. And we go on syndromes, and the syndromes can be quite predictive to, what species are in your area, but nothing specific in Southern Africa.
I think in India it's quite straightforward. Bite plus swelling plus blood is a viper. Bite plus swelling plus pain plus no blood is usually a cobra. And respiratory paralysis, neurology with no pain, no marks is probably a crate. And
awesome.
Those are the simple way. I think there's an interesting question about venomous snakes in the UK. Yes, we have the adder. We have the adder, which I think the last death from the adder was in 1974. It was a child, a 12-year-old person that got bitten by the adder. They are around. They will affect your pets. So I think there is a a worry that pets that are on moorlands and heath that can be bitten by an adder, and it could be fatal to them. But you've got to also remember there is a very huge trade in venomous reptiles in the UK. You can buy a cobra from Dorset for about £50 cash. And there's a large increasing growing trend in actually keeping venomous reptiles. So you may, if you work in the A&E in the UK, you may still find that you might get a venomous bite if we consider it. And I think also a lot of paramedics may end up being called to a premises where they've got venomous snakes. So it's still worthwhile noting if you live and work in the UK.
Yeah, absolutely. And I've certainly seen one in Kings in the past that's come in that's been bitten locally, and it wasn't an adder. I'm on my way to the north of Scotland and we have adders up there. And so we all wear hiking boots to cover our ankles when we go for our walk. But I'm always told to be really quiet when I see one because they're more scared of me than I'm of it. So I usually scream and jump half a mile, much to everybody else's amusement, because I don't like snakes.
Guys, there's a question which has come across directly to me from, he says, can you tell us a little bit about the prophylactic adrenaline? How often do you use prophylactic adrenaline? What dose do you use? Darryl, you mentioned an infusion and you called it low dose. What actually is low dose, and in what cases do you use it?
So with all cases, we would give a pre-dose adrenaline if you're not doing an infusion. So it'll be intramuscular dose, similar to what you would use for anaphylaxis, standard as pre-dose. And you'd wing it from there. And then if they went into shock post that, you would give a second dose after the antivenom's in. For low dose adrenaline, you'd be looking at about 5 microgram per kilogram per minute, which is on the lower scale. Nothing more than that. It should be adequate. It's mainly to maintain vasotone, and it's a short-lived anaphylactic shock. It doesn't last significantly long. And if you treat it appropriately, and a low dose infusion, really you need to be in a high care ICU setting. And, with adrenaline infusions peripherally can be a problem as well. But if you've got the settings, it's preferable to intramuscular because you can control it. But antivenom works really well. The big problem with adrenaline is, I don't know if anyone can guess, is it causes tachycardia, right? So you give a pre-dose and the patient immediately goes tachycardic. So the early sign of shock is tachycardia. So you don't know if they're going into shock early. And the way around that is what we would do is you would take the patient's radial pulse throughout the administration of adrenaline. And when you're losing the radial pulse, you have a patient going into shock. The next thing they would be getting a little bit drowsy and the level of consciousness would drop, and blood pressure is really a late sign. So you've got to be on it when you're giving antivenom. I hope that answers it.
That's great. Any more questions direct to you, Tim?
Can I make a comment for UK clinicians? I think that there's a very, very useful tox-based protocol for snake bites, because there are three major centres, Liverpool, Birmingham and London, and there's somebody on call 24/7 for snake bites. I think if you look at Talkspace and do snake bites, it's got a very clear instructions. I think for us in the UK is actually consider a snake bite in somebody that you might think of taking cocaine or ecstasy. And I think this is going back to taking a good social history and actually considering snake bite. But I think that there's a really good resource. Another very good resource is the WHO handbook on snake bites that Professor Worrell's written for the Southeast Asia scenario and the African scenario, and the one for the Indian subcontinent was updated in 2016. It's freely available to download as a PDF, and it's incredible. It gives you every dose scenario on what to do for each species of snake. So if you've really got an interest, I've read it 4 times now because it's such an interesting thing to read. But if you're interested in snakes and snake bites, Professor Worrell's papers and the free WHO resources are really good.
Thank you, Chet. I wonder maybe you could put the links to those into the chat whilst Prof does the next part of the talk. So I think if there's no more questions from the floor, I'd like to say a huge thank you to Darryl and Chet for that really fascinating talk. And there's so much to know and to learn, and it's really important, especially for people working in the UK, as well as those who go and travel abroad, to be aware of all these things. So thank you very much for sharing that. And we will be sharing the recording of the talk afterwards once it's been edited down, so you'll be able to share that with your colleagues. And lots of lovely thanks coming through on the chat. So thank you for that. So I'm going to hand over to you now, Prof. Harris.
Libby, thank you as always for the introduction, the comparing, and thank you to Chet and Darryl. That was fascinating. I learned a lot. The only snake bites I saw were in Australia, which was a reasonably common presentation to EDs, particularly in Queensland. But let us move on and talk about the suite of MSCs. Obviously, Libby, Darryl, and Chet are working with me and others in our emergency and resuscitation and our new tactical military austere and operational either MSCs or diplomas. And what I'd like to do is introduce you to those diplomas over the next 10 minutes. We also run a pediatric masters, but that's a slightly different masters using a different educational model. So I'm not going to cover that today. So why might you want to study emergency and resuscitation? Well, for many of us, this is a subspecialty interest. Many of you may have subspecialty interest in toxicology, in ultrasound, in major incidents or in management. But perhaps more recently, a number of people have thought, well, actually resuscitation probably should be a subspecialty. That doesn't mean we don't want all emergency physicians, acute physicians, trauma surgeons, etc. to be involved in it, but it means for most of us, this is a reasonably small part of our patient load, but a very significant part of our patient mortality, and of course the costs and times that we involve in our jobs. So perhaps by having leaders within this field, within your emergency department, within your pre-hospital care, within your nursing colleagues, perhaps this will improve patient care. You can learn about running scenarios, about the latest literature, about translating that literature to good protocols, to good guidelines. And of course, you can take leadership roles in developing your resuscitation areas and strategies. So, for tactical, military, austere and operational medicine, we've designed an MSc which is looking for those that are involved in military or paramilitary or extreme roles. This would suit people perhaps that are going to be deployed out to Antarctica. Perhaps they're involved in the next big pandemic, or perhaps they're involved in a disease like Ebola, or perhaps they're working at home and they're doing some part-time military work, or perhaps they're working with SAR or with CBRN. Perhaps they're just deployed occasionally with the police and they want to learn more about how to deal with extreme environments. The emergency and resuscitation masters is really designed for those of you that meet the bill I said earlier, that you work in an ED, in a critical care situation, in or out of hospital or pre-hospital, and you'd like to see yourself as a leader in that field. A leader might be a researcher, although this master's is primarily not research based, it's clinically based. It might see you as a leader in developing protocols and running education, or simply spending more of your time there and offering better standards of patient care. I'm going to introduce the faculty. So Paul Rees is an interesting character in that he works pre-hospital and in cardiology and as a defence professor. He works both in Scotland and in Barts and East Anglia. And he leads the TMA overall. And he's supported by Steve Bland. Steve Bland is the NATO lead for CBRN and works as an emergency physician in the UK. Bill Justice is also involved in TMA. Bill is a senior paramedic and vice dean of a medical school in the US and very much involved in the 4C course. Ben Bloom is a senior lecturer in QMUL in London and runs our module 1, which is all about statistics and research. Tessa Davis is also a senior lecturer at the London and at QMUL, and she runs our paediatric masters. Libby, of course, you've met. Libby has a PhD in simulation and works both in teaching and in emergency medicine in a clinical role at King's and with us, of course, at QMUL. Stephen Thomas is an emergency physician out in Qatar. He's an American trained physician. He used to run the training program, the residency at Harvard in emergency medicine, then moved to the southern US and now joined us here. And this year he was inducted into the top 1% of scientists overall worldwide, which is a phenomenal achievement. Darryl and Chet, of course, you've just met, and I won't reintroduce them because they've already explained their backgrounds. And my name is Tim Harris. I trained in emergency medicine, pre-hospital care and intensive care medicine, and initially in pediatric medicine. I trained in Australia and in the UK. We have a much, much wider faculty who have given us their lectures, their time, they join us in the tutorials, and it's an honor to have them. You can see Libby's smiling face top left, then Chris Cabul, who's Professor of Emergency Medicine in Harvard, Brian Burns, you may know from Life in the Fast Lane, Gareth Davis, you'll know from HEMS, Maurizio Ciccioni's chair of the Intensive Care Society, used to work at George's and has now gone back to Italy. Chet, of course, now sporting a new COVID hairstyle. And then we've got Barbara Bacchus, who developed the heart score and is an emergency physician in Holland. And then you can see underneath those is Scott Weingart, and then coming left, Mervyn Singer, who's chair of intensive care at UCL. Then we've got Mark Wilson from his pre-hospital app for brain apnea, and of course Mark is a neurosurgeon, and so on. I won't run through everything, but we have got a superb faculty and it's an absolute honour to work with these people. So what are we proposing? What would we like to interest you in? So we would ask you if you'd be good enough to consider studying with us for 3 years to do a master's, 1 year to do a PG cert, or 2 years to do a diploma. So this is level 7 education. This is teaching you to think for yourselves. We want you to be the ones that develop your protocols, run the simulations, develop and improve the skills in your resuscitation environments and area. This is an online course, so it's designed for dissemination worldwide. We do have a summer school, unfortunately binned by COVID these last couple of years, but other than the summer school, everything is online. The first 2 years consist of 8 modules. Each module is 8 weeks, that's 4 modules a year. The modules are delivered by releasing somewhere between 3 and 6 lectures each week. The lectures vary from 30 minutes to one mammoth hypothermia lecture of 2 hours. So I hope you like hypothermia. And we meet weekly for a tutorial, which is on Thursday at either 11 or 1. The tutorials are there to discuss the lectures, to come up with questions, to use cases to highlight what we've learned. In the 3rd year, you'll have the opportunity to do a scientific paper or dissertation. The scientific paper is aimed for you to produce something which you will publish in an area that you are passionate about and interested in. Summer school, we hope, will be up and running next year and will involve some teaching in ultrasound, some simulation, some lectures, and some tutorials, and that will be run by Libby. So let's have a look at the structure. So both the MSCs share the same first year. We start off with the fundamentals of research led by Ben Bloom. We teach you to identify literature, to read papers. We teach you about ethics, about some research design, and of course we introduce you to everyone's favorite topic of statistics. Then we move on to the nitty-gritty. This is a module run by me on the pathophysiology of shock. We talk about shock syndromes and the tools of resuscitation, what fluids to use, how much fluid to give, when to use oxygen, and the classification of shock. In module 3, run by Darryl, we look at cardiac arrest. We go into great detail on airway management. We look at analgesia and sedation. So that's really the interaction with anesthesia in emergency medicine. Module 4 is looking at emergency care. This is where we look at all those background diseases that lead to shock and the compromise of your patients. So we've got talks on ACS, talks on STEMI, we've got talks on COPD, on asthma, on renal disease, and so on. And that is led by Paul Rees. In year 2, both MSCs start with Darryl's emergency management of severe trauma. We then go on to look at diagnostic tools in critical care. So we look at venous gases, ECGs, chest x-rays, but above all, we look at ultrasound, because ultrasound, particularly echo, is the key to you diagnosing shock, classifying shock, and leading an accurate evidence-based resuscitation. For those of you that want to study TMA, you will be doing medical care at the extremes. So that's care in the battlefield, care in extremes in UK, in terrorist situations, CBRN situations, and extremes is also for environmental extremes, heat and cold. In the E and R, we will then move to module 7, looking at toxicology and CBRN. This module is run by Libby and Steve Bland. And for those of you that are doing the TMA, you will do a CBRN, but a more detailed CBRN, and look at some environmental medicine. We will then come together to either do a pre-hospital care and mass casualty module. This looks at how we look about patients at scene, the risks of mass casualties, mass gatherings. We'll study major incidents, or of course you can join Tessa for a dedicated pediatric module. In year 3, you'll move on to a 3,500 word scientific paper supplemented by 2,000 extra words on the details of your methods and any extra results you've got, and that is run by Professor Stephen Thomas. So how do we assess you? We're very keen on multimodal assessment. Some of you do very well with presentations, some of you do better with written, some of you with MCQs. So all of our modules have an MCQ component to test core knowledge. If you pay attention to the lectures, you will pass the MCQs. We do some critical appraisal exercises, because reading scientific papers is an absolute core skill at level 7. We want you to go find the evidence. We want you to decide whether we should give adrenaline cardiac arrests. How long should we do it? Should we do it in each phase of cardiac arrest? Because we want you to be working beyond the guidelines. Guidelines are great. We do teach them, we believe in them, but at this level, you should be nuanced in your care, knowing when to deviate, when to apply and what not to apply. And of course, we've got written assignments. These are 1,500 words, and this is a critical essay where you will answer a question, which might be a clinical question, it might be a research question, it might be an evidence question. And finally, last year we introduced PowerPoints, because for almost anybody doing these masters, you will teach. You might be teaching at a conference, you might be teaching your colleagues in resus, in the ambulance service, in critical care, wherever. So we've got a couple of lectures to teach you how to make your PowerPoints more effective, how to teach more effectively, and we've got modules 4 and 8 assessed using these presentations. So what about Queen Mary? So Queen Mary is one of the premier universities in the UK. It's part of what's called the Russell Group, which many of you have heard of. This is the 16 most respected universities in the UK. It's a huge university. We've got 27,000 students. We've got 160 countries represented, and we've got campuses in 4 countries. Our School of Medicine and Dentistry has been consistently highly rated at top in London and the top 3 nationally. And research from medicine has been a world leader for many years. And general research in the university has also been very highly rated across the UK and internationally. The building you can see here is the Blizzard. The Blizzard is one of 5 institutes at Queen Mary, and that's where we're based. It is a lovely modern design. And we're very proud to be associated with Queen Mary and part of the Blizzard team. Barts Health is linked to QMUL. Of course, it's a superb hospital. I'm proud that I've been in Barts Health for so many years. It's home to the largest trauma centre in Europe, of course, to London HEMS, which is the largest trauma service worldwide, London Ambulance Service, the largest ambulance in the world, where we host the largest heart attack centre in Europe and the largest research institution under 1 R&D in Europe. And of course, we are arguably the oldest medical school in the UK and the oldest hospital in the world. So those of us that are working or enrolled there, we got a lot to live up to. So, ladies and gentlemen, I would love you to come join us, come study with us, follow your dreams and improve your resuscitation. So I'm going to stop talking, and if there are any questions, I would be delighted to answer them. And I will just stop sharing my screen and go back to the main screen and hand back to Libby.
Well, you managed to increase the number of people present during your talk, Tim, so congratulations. Does anybody have any questions for Tim? Chet does say it has the best curry houses in the UK on Brick Lane, right beside the university, which is absolutely true as well. You're not actually on the university most of the time, but we do hope to have a summer school where we'll be able to bring students together from across the 2 MSc programs in the summer to meet face to face for those who are able and want to travel to London for that period of time. We just need to see if COVID's going to behave itself next year. So any questions for Tim or for Chet or Darryl, who are both extensive experience on the MSc, or myself?
And of course, if any of the faculty have any other comments or anything that they'd like to add, love to hear from you too. And if Libby, if you wanted to tell us anything further about summer school, because we've had to delay it because of COVID, which makes it even more exciting for next year, when hopefully most of this pandemic will leave us in peace to return to normal life.
Chet, you wanted to say something?
Yes, I think I agree with everything Tim said, but I think in addition, you've also got mentors and sort of supervisors to guide you through the whole thing. So you're not on your own. So a lot of people get daunted by writing papers or dissertations, but you've got support and we're there for you for every step of the way. So, you know, lots of exciting things, but there's a lot of support as well. So I think, you know, we just want to make sure that you don't feel that you're going to be lumped into it. So irrespective whether you're a medic, a paramedic, you know, don't be scared. You know, there's something for everyone in this MSc.
I think that's a really good point, Chet. And what we're really working on in the new year is how we can support students from different backgrounds and different academic experience so that you can learn from each other and share and help each other to get better and better. Because studying at a master's level is a step up from doing undergraduate degrees. And we do have a grandfather program, so people can get in if they are very experienced in their fields, but didn't come through a BSc because it didn't exist in paramedic or nursing science at that time. So you can apply, and that Tim has a special system through a dean's approval that allows people to join if you've got a certain amount of experience and depending on personal statements and things like that. So the information for that is up on the website, which is great. And we do look to support those students and help you get the most out of being on the MSc program. And I'm sure we have continued support as well. So I've had an email this week from a previous student who now wants to do a PhD and looking to see if they can do that in QMUL and trying to see if how we can continue to support them just beyond the MSc program, which is really exciting. About the summer school program, the idea for that is to bring people together for some practical experience and also to learn from and with each other. So pulling together the 3 professions and your national and international experience. So with a central core program that's based around simulation scenarios and opportunities to practice ultrasound for those who don't get that as part of their core curriculum. There's combined with opportunities to visit an air ambulance, working air ambulance, also to promote, to add on some courses that can be run specifically mainly by Paul Rees around sort of REBOA and ECMO and looking at about those sorts of different highly advanced pre-hospital supportive measures. So, and we're always looking for more ideas. On top of that, there's the opportunity to socialize, to get to know each other, to create networks and to create friends, which is really important in emergency medicine. And we're following on from the great example of Karim Brohi and the Trauma Sciences MSc program that's been running out of the same institute for over 10 years now. And their summer school is a highly important and well-regarded part of their program because it allows people to make these long-term connections. So you can travel the world and you can say, oh, I know somebody in that country, or they're a common student, and let's get in touch and let's see if we can help each other out, or can I go and get work experience or opportunities in other places? And I think that's really key. My passion is interprofessional education. The more you can learn from and with the other professions, the better we can work together, the better patient care will be, the more safe patient care will be as well. Any other questions from anybody or any other final points from the faculty before we sign off for the evening?
Libby, just to reinforce what you said, I mean, the inspiration from this MSc came very much from pre-hospital care, where doctors, nurses, paramedics work together, and what we can learn from each other and recognizing each other's different skills and different abilities. And of course, for those of us in emergency medicine, it's the coffee shop, isn't it? Everybody walks in, walks out. And one of the pleasures of it is that we work with such a range of colleagues. And if you join the MSc, you will be welcomed by a wide range of colleagues, both faculty and students. I think we've had students from every continent except Antarctica. And we've got faculty from every continent, I think, except Antarctica. So it's a very diverse group, and we would love you to join us. Thank you very much for joining us here today.
Thank you all. Do feel free to get in contact with us. There is a quick question there for you, Tim, from, so I'll let you answer that directly in the chat. He's a qualified 2 years ago and has been first class on BSc nursing.
Yeah, so the short answer is yes. So when we initially set up the Masters, we asked for paramedics and nurses to have 5 years experience and doctors to have 2. To have 3. Of course, that's because the doctors are studying for 5 years and the nurses and paramedics for 3. So the idea was we had people that joined us with 8 years of medical nursing paramedic training. We actually changed this last year because we had a lot of students that wrote to me individually saying, hey, I don't meet your entry criteria, but this is the right time to study. It may be the right time socially, having kids later, buying a house later. It might be because people had come off their undergraduate programs and just said, hey, I've got a mindset to study and I want to continue. So we let some students in that had lesser experience, maybe only 1 or 2 years. And actually those students have done very well. So we've done what every other Masters did, which is to let people in once they've been assessed and completed their undergraduate training. And as Libby said, we have an arrangement because we recognise there are some very, very skilled practitioners who simply did not have the opportunity to do a BSc or equivalent. And what we ask those to do is prove a commitment to lifelong learning, prove a commitment to leadership and education. So that would be filling your application with courses you've attended, describing your role, how the Masters would help you, and proving to me that you've got the necessary background to study and the commitment to study. And then we move on and get a thing called Dean's approval. There's very few Masters that do this. And what essentially it means is I vouch for those applicants. And actually those applicants have been amongst our keenest students. There's no doubt that people that come to us without an educational background and a BSc find some of the modules harder, they need a bit more support, but at the end of the day they seem to get a lot out of the course and they pass the course as well as anybody else. So the short answer is yes.
Brilliant. Thank you so much, Tim. That's fantastic. Well, thank you to David Bell for organising this. He'll be in touch and he'll let you know about the recording and when that's live, so you can share this with your colleagues. We'll be sharing it via Twitter. And if you're interested in doing the Masters programme, as David has put in the chat, do contact the emergency med at qmul.ac.uk email address with any further questions or apply. And we would love to get your applications in. They're due in by the end of August for this year, if anybody's interested for this coming year.
And Libby, would you like to say something about the student presentations seminar? Because it might give these guys and girls an opportunity to hear what some of our students have got to say.
Great point. Tim, thank you so much. And David's going to send out details, I believe, after tonight. But we're having another webinar on Thursday evening where we're going to showcase some of the presentations done by our students in just finished their second year. So these were top scoring presentations, one from a nurse, one from a paramedic, and one from a doctor, about their mass casualty response in their areas. So it's geographically from Scotland, Northern England, and Southern England. And we do hope you can join us, and it'll be followed by a Q&A with the students, so you can ask them the questions about the course and what you want to know about it, and I will grill them some questions on your behalf as well. So we do hope, if you want to join us on Thursday, that'd be fantastic, or if you have colleagues who do as well. The sign up details are on Twitter if you follow us at Resus Masters, and I think David will be sending them out after this webinar as well. So thank you all so much. Have a lovely Tuesday evening. I hope it's not pouring with rain where you are. Yep.
Sorry, there was a question. How long does it take for the online applications? So the answer is, when you apply, initially your application is screened by the applications department. For those they'll look at your qualifications. Is your university registered? Is the degree seen as equivalent to a UK degree? They may write and ask for your transcripts. That process varies from, depending on where you trained and the university you trained in and what transcripts they give you. You then are passed to me. I review every single application myself. I pretty much do those within 48 hours of receiving them. Then the references are there. The references are really to prove that your colleagues, your employers and your boss support you and that you've got time, because doing a master's program is a pretty significant undertaking. It's a valued addition to your CV, and it's valued training because it is hard and because it takes 12 to 15 hours a week. So the processing of that application to ensure that the person is suitable and supported takes anything from 3 to 6 weeks. Occasionally it can take a little longer during the peak times. COVID did slow things down. For everybody, it slowed the whole world down, didn't it? And if you are worried because your application has not got back, I know QM are behind at the moment, but they're catching up, and I think we'll be up to date within the next week.
Yeah, I think they've been catching up on A-level results that came out in the UK today, so there's going to be a massive scramble with clearing and those elements as well. Anything else, Tim?
That's all from me. Thank you. Darryl, Chet, that was great. Thank you so much. Libby, thanks for comparing. And to all of you, thank you for sharing some of your evening with us. And I hope the rest of your evening or day or whatever time it is, depending on what particular part of the planet you're based in, is going to go well for you. Take care.
Thank you, Chet and Darryl, you're stars. We loved it.